morning. We'll start the session. The session is on ocular trauma, special scenarios. The first speaker is Dr. Yasser Safar. His topic is on traumatic retrobulbar hemorrhage, intraorbital foreign body and animal bites. He is a consultant in orbit and oculoplasty at Agarwal Eye Hospitals, Trivandrum. Over to you, Dr. Yasser.
Good morning, warm welcome. So this being the first session, we'll go on to the topic straight away. So we'll be discussing on orbital trauma, especially retrobulbar hemorrhage, orbital foreign body and animal bites. So retrobulbar hemorrhage, as known, it's an accumulation of blood in the retrobulbar space, which is a rapidly progressing sight-threatening emergency. The main cause obviously being trauma and periocular injections and surgeries. And sometimes it can occur spontaneously also in especially patients with uncontrolled hypertension, septicemia, etc. The signs and symptoms being periorbital pain, periorbital ecchymosis, eyelid hematoma, ophthalmoplegia, proptosis, sudden visual loss, and subconjunctival hemorrhage or hemorrhagic chemosis. And the patients will have severe nausea and vomiting also. Why is it an ocular emergency? To know that, we will have a quick recap on the anatomy. The orbit being an orbital volume being 30 cc, being enclosed 360 degree mostly by the bone, and only the anterior surface being open, and has rich vascular supply also. So any bleeding into the orbital space, which being a source space, can lead to can lead to accumulation of blood in the orbital cavity, which lead to orbital compartment syndrome. Any bleeding in the compartment which leads to optic nerve stress and damage, and which eventually lead to ischemic vaso-occlusive crisis, including CRAO. So when a patient presents with any history of trauma or any periorbital injections or surgery, if the patient is presenting with acute onset of pain, proptosis, periorbital ecchymosis, and sudden drop in vision, you should immediately measure the visual acuity, intraocular pressure, and have a comprehensive ophthalmic examination of the patient, including ocular motility and fundus examination. Look for spontaneous venous pulsations and spontaneous arterial pulsations also. If possible, try to measure the intraocular pressure. And severity of the RBH can typically be determined by the physical examination findings rather than any imaging studies. It's a sight-threatening emergency, and clinical diagnosis is the dictum, and it needs emergent treatment also. Imaging is not recommended for initial diagnostic purposes. CT scan may be done to visualize the orbits, particularly to rule out any concomitant injuries also. So if you diagnose a retrobulbar hemorrhage, be a ninja, there is no time to wait. The intervention should be rapid within 2 hours of onset to avoid any permanent damage. Surgical management is preferred, or medical management, and concomitantly you may give IV acetazolamide or hydrocortisone. The first line management being lateral canthotomy and inferior cantholysis. So give local anesthesia to the lateral canthal area, crush the lateral canthus and cut it with the scissors, whatever you have in the OPD or in the minor OT. No need to take the patient to the OT even, because it's an emergency. And if the pressure is still not relieved, you can do inferior septectomy and infralateral orbitotomy if needed. If the time has been elapsed and the blood might get enwrapped within the numerous fibrous septae within the corner space. In short, it's the hemorrhage in the posterior muscle cone. It's a space occupying lesion which leads to sudden proptosis, pupillary dilatation, reduced vision, high IOP, and eventually lead to permanent visual loss. Coming to orbital foreign bodies are any foreign object partially or completely within the orbit. It may be there with or without penetration or perforation of the globe. And it can either be purely orbital foreign bodies, or it can be transorbital foreign bodies, where it can reach the adjacent space like intracranial space or paranasal sinuses. Or it can be either occult or overt foreign bodies too. So the etiology being most commonly being any trauma, especially accidental injuries or industrial accidents. Sometimes it can eventually lead from assaults also, domestic and motor vehicle accidents, high velocity projectile. Sometimes it may be diagnosed incidentally. The patient might have forgotten the history of trauma, especially if they have some sharp injury, having a self-sealing wound, which should have lodged the foreign body within the orbit. As in any trauma, it most commonly occurs in young men, working age men. It can be either metallic or non-metallic, or even organic materials also. So 89% of the ocular orbital foreign bodies are associated with other ocular injuries like corneal aberration, iritis, retinal detachment, and commotion retinae, and 7.4 are associated with open globe injuries. And transorbital foreign bodies are also there, wherein it can lead to paranasal sinus or intracranial cavity also. So the pain symptoms as such are visual disturbance, pain, swelling, droopy eyelid, double vision, and sometimes if it's an overt occult foreign body, it can be asymptomatic even. Make sure that you take a proper history, the history like what is the mechanism of injury, like a projectile injury or any strike on metal will obviously have some metallic foreign body lodged within. And if you notice any entry wound, make sure that you suspect a foreign body unless proven otherwise. Rule out open globe injuries and traumatic optic neuropathy, and make sure that you examine the upper cranial nerves also to determine the penetration to neurological status of the patient. Orbital foreign bodies are often difficult to diagnose, and you should have a high index of suspicion in any patient with orbital trauma with any periorbital penetrating wounds. And it may need multiple examination and additional imaging for the diagnosis. So plain x-rays may be taken as a screening test, especially in the OPD setting, if you suspect a metallic foreign body. CT scan is the first line imaging. CT scan not only of the orbit, but you should make sure that you take a CT scan of the orbit along with the brain. It's a first line imaging study after the trauma. And make sure that you communicate properly with the radiologist. As in this case, it's being reported by a patient had a fall and had a nasal bleed, primarily sent from the ENT department without any proper communication, and it's reported as orbital blow-in fracture with intraorbital air pockets. And the patient, when cross-referred to ophthalmology, had significant motility restriction, and when the CT imaging was reviewed, there was a large foreign body which has pierced through the nasal cavity into the orbit. So proper communication is must, especially in organic foreign bodies like wood and organic material. And MRI is never the initial study of choice after trauma, but it's reserved for if you suspect a wooden foreign body, and make sure that you rule out any metallic foreign body before ordering any MRI. And if there is recurrent or chronic orbital inflammation where organic and vegetative matter is suspected, you can order an MRI. B-scan ultrasound can be done along if you suspect an anterior orbital foreign body, but it's highly technician dependent, and it can help you diagnose any retinal detachment or vitreous hemorrhage if associated. Plain radiographs, the problem is like it may underestimate many materials like graphite, plastic, fresh or dry wooden foreign body, etc. Management: most foreign bodies are metallic in nature, but they are relatively easily visualized on imaging, but it's not the same way while in raw, because orbit as such every all time it says a Pandora's box. Surgical options, so it should be individualized, and you should weigh the risk of surgery as in and the risk of retention. Weigh the risk of surgery and the risk of retention as like infection, inflammation, and fistula formation. Open globe injuries should be immediately repaired before exploration for the orbital foreign bodies. So surgical intervention absolute indications are neurological compromise, mechanical restriction of eye movements, development of acute or chronic infection, and chronic suppurative reactions to foreign bodies. Small, inert, and deeply lodged metallic materials may be managed conservatively, and it will be well tolerated if left in place, and the patient will be advised no further MRIs. Most metals are inert, but some may lead to serious complications, especially lead, copper, and iron. Larger foreign bodies have a higher risk of penetrating into the surrounding structures, and surgical removal should be attempted. Meticulous planning should be done before executing the removal of the foreign body. Organic foreign body, there is no choice, you have to remove it completely. If observation is preferred, the patient should be notified and carefully monitored, as it can lead to chronic inflammation, abscess, and fistula formation, and appropriate counseling should be done for the patient, and documentation should be done for the risk of long-term infections and the migration of the foreign body. Tetanus prophylaxis has to be taken. Broad spectrum antibiotics has to be given to the patient, considering the type of injury. Anaerobic coverage and even antifungal coverage may be needed. Antibiotics with good blood barrier penetrations are recommended. A combination of third generation cephalosporin and vancomycin might help. So complications, as said earlier, infection, sinus infection, non-infectious inflammation, migration, and even Gay-Sivok amaurosis can lead. So the outcome basically depends on the severity of the inciting trauma and the material causing the trauma. Anterior located foreign bodies without any globe injuries have a better prognosis as compared to the others. So prevention is always better. Periocular animal bites and injuries, it's relatively common complaint in the ophthalmic emergency room, and young children are most commonly involved. And relatively, the face and periocular regions are involved because the dogs have a predilection to bite in the face, and the young kids they are short in stature and have a poorly or a developing motor skill. So it can vary from abrasion, punctures, laceration, and even to a crush injury or luxation of the globe. So open globe injuries are relatively rare because the eye is protected within the orbital cavity, but henpecs and others can lead to open globe injuries and cat paws as such. Canalicular lacerations are pretty common, so if you find any medial lid laceration involving the medial canthus, make sure that you examine for the canalicular laceration, and if it's there, you have to repair it with silicone intubation. Orbital fractures are pretty uncommon with animal bites, but it can occur if the biting animal is large, like large breed of dog, or if you have sustained any animal hoof injuries or anything like that. This patient being hit by the cow hoof. So most commonly involved bones are nasal, maxillary, and orbital bones. The problem with animal bites are the oral cavity of the animals have a pretty large lot of microbes, and the infections rates are the chance of infection is quite there. But though the documented rate of infection is less, but because the orbit and the periocular area has rich vascular supply, but if there is an infection, it can communicate with the skull base, and potential pathogen has a direct access to the intracranial space. So there are over 64 species of bacteria found in the canine mouth, and many of them are having antibiotic resistance also. So complete physical examination is mandatory. Medial eyelid laceration, look for canalicular tear, high suspicion of orbital fractures if there is any extensive orbital wounds, and you can take a diagnostic CT scan in such patients. So management guidelines, primarily being disinfection, exploration, and wound closure. So thoroughly irrigate the wound, judicious debridement of the wound, early wound closure might help. Prophylactic systemic antibiotic, amoxiclav can be helpful. If they are allergic, can give trimethoprim, sulfamethoxazole, clindamycin, ciprofloxacin, or acetaldehyde. Tetanus vaccination has to be done depending upon the patient's immunization status, and anti-rabies prophylaxis if needed. And this is the WHO recommendation of anti-rabies prophylaxis. The face being a highly innervated area, if you see blood, it's better to give anti-rabies vaccine along with the immunoglobulin. Thank you.
Thank you, Dr. Yasser. I've got a doubt. Dr. Yasser, what about, so we see that when there is an animal bite, there is a high
Yes.
risk of rabies
Yes,
if it
ma'am.
is in the face. So normally in the other extremities and all, you infiltrate immunoglobulin at the wound.
Yes,
So what
ma'am.
do you do in case of eyelid injuries?
It's better to infiltrate, ma'am.
So
There is, as such, the WHO recommendation is there is no need to even to test for allergy. You have to infiltrate. The face, hands, and neck region are highly innervated, so even despite not even to check the immunization status of the biting animal, you have to give anti-rabies vaccine along with serum.
if there is no lead injury, but it's mostly a globe injury, what do you do then? Any infiltration is given like that in the immunoglobulin?
Not
Only in the skin part it is
lid
given.
part we do give.
Okay.
Yes, ma'am.
So next I call upon Dr. G.S. Kalemati for her topic, Firecracker Injuries and Occult Globe Rupture. She's working as a consultant at Giridhara Institute, Kochi.
Good morning, everyone. My topic is on firecracker injuries and occult globe rupture. Ocular injuries due to firecracker work accounts for 14% of the firework injuries, and 65% of all firework injuries are to the bystanders. Ocular injuries are due to three effects: mechanical, thermal, and chemical. The mechanical is due to the pressure involved due to the ejection. And what is it is made of? It is made of cardboard or plastic. The propellant is a black powder which is potassium nitrate, which is dangerous to the eye, and its other ingredients are magnesium hydroxide, charcoal, sulfur, and lithium. These are poisonous to the respiratory tract and irritates the eye, nose, throat, and skin. The chemical injury overlaps with the thermal and mechanical injuries. The magnesium hydroxide causes devastating injuries, both thermal as well as chemical. It penetrates the eye deeply. The mode of injury is 51% is because of the misuse behavior and 31% is because of the device failure. So mechanical eye injuries can be divided into closed globe and open globe. I am not going to go to the details. The range of firecracker injuries, it ranges from the superficial foreign bodies to the open globe injury, traumatic cataract, etc. So initially we have to manage the full thickness corneal and scleral injuries. So and we have to image to rule out the intraocular foreign body, and decision making has to be done whether to do the cataract extraction in the primary as a primary procedure or a secondary procedure, and wound exploration has to be done to look out for any foreign body or any other tear. And if the lid edema is profuse, then we have to examine the patient under general anesthesia. And if the corneal foreign bodies are multiple and at multiple different levels, then we have to remove only the superficial foreign bodies, and the deep-seated foreign bodies can be left alone. So the management of the firecracker injuries can be dealt in 4 headings. First is the ocular surface management, eyelid management, glaucoma management, and the posterior segment management. The ocular surface management, we follow the Duos classification, and it takes into account the limbal ischemia and the conjunctival involvement. If the limbal ischemia is less than 6 clock hours, then the prognosis is very good, and if there is total limbal ischemia, only then the prognosis is poor. In between, with 6 and 9 clock hours, we can always give a good to guarded prognosis. The initial management consists of the vision testing, copious irrigation, the removal of all particulate matters, doing a double eversion with under topical anesthesia, and topical steroids for 10 to 12 days. And it should not be given beyond 2 weeks because of corneal melting. And white eye is an ominous sign. And if the scleral ischemia is extensive, then we can go for a tenonplasty. And if there is persistent epithelial defect, it means that there is loss of stem cells. Then in that case, we can go for amniotic membrane grafting, and if there is spannous formation, we can go for SLIT, that is simple limbal epithelial transplantation. In that case, we have to remove the pannus, place the AMG, put the limbal tissue from the fellow normal eye, and stick those limbal tissue with glue, fibrin glue, and place the BCL. In case of if the stroma is involved, then we have to go for lamellar KP and AMG. And if it is a severe injury and if the eye is moist, then we have to go for Boston Cape Pro. And if the eye is dry, we have to go for osteoodontokeratoprosthesis. And coming to the eyelid management, eyelids are usually protected by blink reflex and Bell's phenomenon. So the ocular sequelae is because of the post-burn eyelid deformities. So the initial examination is important before the edema sets in. So examine for the periorbital skin and for any eyelash losses. The first degree burn involves the epidermis, so there won't be any deformities. The second degree burn involves the papillary dermis, so there will be dermal fibrosis leading to ectropia. The third degree burn will involve the reticular dermis, so later on ectropion and lid shortening can be there. And full thickness burn will involve the subcutaneous tissue and muscle, and that can be contractures later on. The complication of eyelid injuries can be lagophthalmus, exposure keratitis, trichiasis, and entropion. So the management involves stabilizing the patient, examining the globe, irrigation of the wound, removing the dirt and sloughed skin, sweeping the fornices with moist skin tip applicators, and trimming the burnt eyelashes with ointment covered scissors. So, broad spectrum systemic and topical antibiotics should be given, and antibiotic eye ointments can be applied over the eyelids. Preservative free lubricants can be used, and topical povidone iodine ointment can be used for the face. And if dressing is needed, lubricating dressing with styrofoam gauze can be used, and Pseudomonas is a common infection in such conditions. Surgical interventions are lateral canthotomy and cantholysis in case of orbital compartmental syndrome with high IOP and APD, suture torsorrhaphy with bolsters, or surgical torsorrhaphy can be done. The leg of thalmus can be reduced by releasing the contractures, and lacrimal system should be taken care of by in the early stage by daily punctal probing, and in late stage by punctoplasty, canaliculoplasty, and canalicular stenting. In late stage, we have to manage the ectropion, and eyelid grafting is needed in very bad cases, and management of the sequelae. Coming to the glaucoma management, glaucoma can occur both in closed and open globe injuries, and it's more common in closed globe injuries. The common tissue injuries during firecracker injury is iris sphincter tear, iridodialysis, angle recession, cyclodialysis, trabecular meshwork tear, zonulodialysis, and retinal dialysis. In closed globe injury, the high IOP is because of inflammation, hyphema, subluxated lens, and dislocated lens. In low IOP is because of hyposecretion, TM tear, cyclodialysis, and occult globe rupture. So check the IOP with GAT or eye care, and we can defer the gonioscopy for a week. The increased IOP because of inflammation and hyphema can be managed with steroids, cycloplegics, and anti-glaucoma medications. The subluxated anterior lens can give rise to secondary angle closure glaucoma. So YAG PI should be done immediately, and elective lens removal should be done. Dislocated anterior lens is an emergency because it can give rise to corneal decompensation. So lens removal should be done under mannitol. Glaucoma due to open globe injury occurs later. So if the meticulous repair is done in the initial and during the primary repair, and if good AC reformation is done, we can avoid this glaucoma formation. And overall, glaucoma is initially managed medically. If not under control, then we have to go for trabeculectomy or tube or cyclodestructive procedures. Anyway, lifelong follow-up is needed for such patients. Now coming to the posterior segment management, first maintain the integrity of the eyeball, then go for the posterior segment surgery. Orbit PA view is mandatory for medico-legal cases. Then CT scan for the exact location of the foreign body should be done. MRI can be done for non-metallic foreign bodies. In case of cyclodialysis, it can be sutured to the sclera. Prophylactic intravitreal antibiotics can be given to prevent endophthalmitis. And if you see something like this 360-degree subconjunctival hemorrhage with chemosis, then we have to suspect posterior scleral perforation. In that case, we have to do 360-degree peritomy and suture the perforation. So to conclude, the prognosis depends on the severity of the injury, and it needs multiple specialty to manage. The education of the public and children on firecracker safety and first aid is necessary. Prevention is always better. Wearing protective eyewear, wearing cotton clothes, purchasing crackers from legal manufacturers, and keeping fire extinguishers ready at hand. Thank you.
Thank you, madam. Madam, normally for firecracker injuries, do you always do CT orbits to rule out intraocular foreign bodies?
Yeah,
what
depends.
Is the normal protocol?
Yeah, it depends. Initially, it all depends upon how severe it is. But it's always better, at least just, orbit X-ray is a must.
The problem with these the firecracker injuries are that the entry wounds may be very small. So you can get intraocular foreign bodies without much of an external entry wound. So it's always better to do a CT orbit, I think, for medical legal purposes also. So you don't miss anything.
Yeah.
Thank you, madam. Now let me invite Dr. Sarah Jacob for her topic, traumatic lens injuries, how and when to intervene. She's senior consultant at Giridhar Eye Institute, Cochin.
Good morning all. Thank you KSOS for this opportunity and Dr. Kalaimati for this opportunity. Traumatic lens injuries, how and when to intervene. Both open globe injuries and closed globe injuries cause a variety of lens trauma. We should be cautious not to approach traumatic cataract as a typical age-related cataract. This is because half of the traumatic cataracts have associated posterior segment damage, and the diagnosis of traumatic cataract is challenging in the presence of a hazy media. The cornea will be hazy, there may be hyphema, fibrin, and the pupil may be non-dilating. Overall, the classification can be done as a total cataract, membranous cataract, white soft cataract where the anterior capsule is ruptured, and a rosette cataract. The clinical assessment should include a comprehensive history regarding the mechanism of trauma, the force of impact, and if it is a mild trauma, there may be ectopia lendis associated systemic comorbidities like Marfan syndrome. Examination should focus on vision, pupillary reaction, and extraocular motility, increased intraocular pressure, AC involvement, vitreous involvement, and fundus involvement. Investigations: B scan when the media is hazy, CT scan to rule out a foreign body when you are suspecting it, and ultrasound, UBM, and swept source OCT may help to assess the status of the posterior capsule. Medical strategies can be tried. We have to control the intraocular pressure and intraocular inflammation. If it is a focal cataract close to the visual axis, we can monitor. If it is close to the visual axis and causing glare, we can give a trial of miotics. Subluxation of the lens can cause a new cylindrical power and the spectacles can be changed. Subluxation of the lens can cause uniocular diplopia and miotics can be tried. When will we decide to intervene? When there is decreased vision, when there is lens-induced inflammation or glaucoma, when there is capsular rupture with lens swelling, and when there is obstructed view of the posterior segment pathologies. So we will consider few challenges while dealing with traumatic lens injuries. Whether we have to go for a simultaneous primary repair and cataract removal or a staged approach. So the advantages of doing a primary cataract removal is that it prevents inflammation and raised IOP. It allows immediate visualization of the posterior segment. It allows early visual rehabilitation of the patient, which is very important in the young children with a risk of amblyopia. And also if there is vitreous hemorrhage along with lens damage, it acts as a risk factor for the development of proliferative vitreoretinopathy. And also definitely it will decrease the overall cost of the patient. Disadvantages are that we cannot truly assess whether it is a traumatic cataract because of the hazy media. The lens may not be truly cataractous, and this surgery, additional surgery, can increase inflammation. Operating room may not be always be prepared to deal with vitreous and cataract surgery. So this is a surgery being done. The primary wound repair is being done, and as the operating room was well equipped and there was not much damage, we went ahead with cataract surgery. This is a patient with open globe injury. Only the primary repair was done initially, but after 3 days, as the IOP was not getting controlled and there was total cataract and rupture of the anterior lens capsule and the IOP was not getting controlled, we went ahead with lensectomy as a secondary procedure 3 days after the primary repair. There is currently no definite guideline regarding this. A case-by-case approach should be made. The surgeon's experience and expertise, and most important, the available equipment and the readiness of the operation theatre, and then the patient-related factors such as age, lens status, and the presence of sonular weakness and vitreous in AC all will help to determine whether you have to remove the cataract as a primary procedure. The challenge too is that if the anterior capsule is ruptured, whether to go ahead with an immediate cataract removal or a delayed approach. So definitely it is better to go ahead with the immediate cataract removal if the lens matter spills into the AC. And also in pediatric cataract, where there is a high risk of traumatic endophthalmitis, if the anterior capsule is ruptured and the media is very hazy, it will be difficult to follow up the young child, and advancing traumatic endophthalmitis may be missed. But it can be delayed if the anterior capsule is compromised but there is no extrusion of the lens material. The visualization of anterior capsule with white cataract is difficult. We can use trypan blue, but if there is severe sonulopathy, this trypan blue can sweep into the vitreous and reduce the red glow. And also a few case reports have suggested that it is better to use indocyanin green than trypan blue if the anterior capsule is ruptured, so that it will not stain the cortex. The third challenge is which surgical technique we should use. When selecting the appropriate surgical technique, consider the patient's age and the condition of the posterior capsule. In pediatric traumatic cataract, early management is essential because of the difficulties involved in examination, the severe intraocular inflammation which follows, and the risk of amblyopia, and the vitreoretinal adhesions are more pronounced in the young age, and it can lead to peripheral retinal breaks if you are exerting traction. Phacoemulsification, SICS or ECC can be done if the PC is intact. And if phacoemulsification in the event of vitreous presentation, we have to go very cautiously. First, we have to do vitrectomy to remove the vitreous from the AC. We have to use dispersive OVD to plug the area from where vitreous is coming out, and we have to do a slow motion phaco. Lensectomy and vitrectomy are definitely optimal when there is PC rent and vitreous loss. This is because the instrument cuts and doesn't pull, and so it doesn't cause any peripheral retinal breaks. The two options for lensectomy are anterior limbal and the posterior pars plana approach. The anterior limbal approach we can do if there is anterior lens dislocation. The pars plana approach is preferred when there is posterior capsular rent and posterior lens dislocation. The other situation other than traumatic cataract is when the cataract is subluxated. So here the rhexis is done and it is started from an area away from the area of sonular dialysis. Capsule hooks are placed. Gentle hydrodissection is done in the area away from the sonular dialysis, and gentle nucleus rotation is done, and phaco, in slow motion phaco is done, which causes less stress on the sonules, and the cortical aspiration is done in a tangential manner. And every time you withdraw the instrument, viscoat is injected through the left side port to prevent AC collapse. CTR is inserted and dialed so that the closed part of the CTR gives maximum support to the area where sonular dialysis is. The CTR is being dialed to the area of sonular dialysis. And a 3-piece IOL is injected into the bag. The fourth challenge is whether to implant the IOL as a primary or secondary procedure. Primary IOL implantation, the advantages are less chance of amblyopia, the synechia formation can be avoided, and closure of the bag can be prevented. Disadvantages are that difficult to do a correct biometry and keratometry, and IOL power calculation can be erroneous. The IOL opacification can occur secondary to the postoperative inflammation that occurs. Conditions in which it is not recommended is primary IOL implantation is not recommended is children less than 1 year and where there is severe damage like severe inflammation, endophthalmitis, significant corneal damage, risk of AC rebleeding, inadequate capsular support, serious posterior segment injury, and increased risk of PVR. Secondary IOL implantation is definitely better in the case of serious ocular injuries because we will know the potential for visual rehabilitation after assessment and treatment of the associated ocular injuries. The challenge 5 is intraocular foreign body. Inert intraocular foreign bodies like glass can be managed by observation. Metallic intraocular foreign bodies have to be removed. They can be removed by lens preservation using magnet, or it can be more aggressively removed by primary cataract extraction and intraocular implantation. So here there is a metallic foreign body which is lodged just under the anterior capsule. Before doing cataract surgery, before removing the nucleus, the foreign body removal is attempted, but it is not possible. So after removing it with a micro forceps, it is grasped and removed. To conclude, selecting the most appropriate therapeutic approaches depends upon factors such as the patient's age, control of inflammation and intraocular pressure, condition of the posterior capsule, and other associated ocular damages. Proper preoperative evaluation and meticulous surgical planning are essential to achieve the best possible outcome. Thank you.
Thank you, Dr. Sara. Okay, the next speaker is Dr. Indu VP. She is a consultant vitreoretinal surgeon in Chaitanya Eye Hospital and Research Institute, Kottayam. She is going to talk about intraocular foreign bodies.
Good morning, everyone. So let's go to the topic, intraocular foreign bodies. Intraocular foreign bodies are a major cause of morbidity in the young population. Manual laborers are at very high risk. High velocity projectiles are commonly produced during chiseling, hammering, drilling, gunshot, bomb blast, and firecrack injuries. They can lodge in any part of the eye, but most of the intraocular foreign bodies are seen in the posterior segment. That is because they are very sharp and generated at very high speed. They sometimes can ricochet inside the eye, they can bounce inside the eye, producing injuries at multiple sites. Intraocular foreign bodies produce damage due to the mechanical effects, introduction of infection, and due to inflammation, and very rarely sympathetic ophthalmia. Basically, they are divided into two, toxic and inert foreign bodies. Toxic foreign bodies are metallic like iron, steel, copper, and aluminum, and non-metallic like vegetative matter. Inert foreign bodies can be metallic like gold, silver, platinum, and non-metallic like glass, plastic, and rubber. So metallic foreign bodies are the most common one. They are usually sterile because of the heat generated. Iron and copper foreign bodies, if they remain in the eye for a long time, can cause metallosis. Organic foreign bodies are notorious to cause fulminant endophthalmitis. Glass and plastic foreign bodies tend to remain inert and they are well tolerated. They are the most common type of mist foreign bodies. Blast or firearm injuries can cause multiple splinters. They can lodge in different parts of the eye. They are very damaging and very difficult to remove. So when a patient presents to you with a history of something hitting the eye, a detailed history is essential. You have to ask him specifically what he was doing at that time. The mechanism of injury and the nature of the foreign body has to be determined. A visual acuity recording is very important. Examine the adnexa and the lids for external injuries and external foreign bodies. And on slit lamp examination, a thorough examination has to be done, specifically looking at conjunctiva. You have to look for conjunctival lacerations, and pigments under the conjunctiva may indicate a uveal prolapse at the site of entry wound. There can be scleral wounds, there can be corneal penetrating wounds. You have to specifically look for iris transillumination defects and a lens track. All these indicate that something has gone into the eye. The entry wounds in small and sharp foreign bodies like iron chips may be very, very small. It can be smaller than the actual size of the foreign body, so it can be missed very easily. Large irregular projectiles like stone particles produce very large and ragged wounds that are very difficult to close. If you're suspecting, if you have a high index of suspicion for an intraocular foreign body, but you're not seeing anything, always do a gonioscopy to rule out an angled foreign body, because if you have a very large arcus, it can be missed. And always, always, always do a dilated fundus examination. It will help you to identify the lens tract and the foreign body in the vitreous or the retina. A photography using a slit lamp or fundus camera helps in documenting the disease and counseling the patient. So here you can see a fundus picture showing a metallic foreign body on the nasal retina. Now, coming to investigations, orbital X-rays are becoming obsolete now because of the overall detection rate is less than 40%. They can detect only metallic foreign bodies, and radiolucent objects like glass or wood can be missed on an X-ray. Ultrasound can locate foreign bodies, and the advantage is that it can also help in assessing retinal detachment, vitreous hemorrhage, and endophthalmitis, but has to be avoided in open globe because it causes extrusion of ocular contents. Metal or stone particle appear as hyperechoic structure with an acoustic shadowing, a high spike on A scan, and it persists in low gain. Wooden foreign bodies also appear hyperechoic, but a plastic foreign body can be missed on an ultrasound, especially the spectacle plastic. PVC plastic can have high echogenicity. A glass foreign body was also bound to be missed on ultrasound because it appears only as a reverberation artifact. Air bubbles can also enter the eye during penetrating injuries. They can also be mistaken for foreign bodies. They produce a single-peaked 100% spike on A scan, and the differentiating features are they may be multiple, they move with movement, and they disappear on sequential scans. So CT orbit is considered to be the gold standard for identification of intraocular foreign bodies. They can very accurately detect the number, size, shape, and location of the foreign body. A metallic foreign body has got a high attenuation. Attenuation means it will be whiter in color. Has got a high attenuation with a shadow artifact and a scatter artifact, as you see here. Whereas glass foreign body will have a high attenuation but no artifact around it. A plastic foreign body also looks like this but with a moderate attenuation. But on CT orbits, organic foreign bodies may have a low attenuation. As you can see here, you do not see much of a foreign body there. So CT is not very useful in case of organic foreign bodies, especially wooden foreign bodies. The problem here is that wooden foreign bodies may appear as hypointense or hyperintense depending upon the water content. So green wood is much more difficult to assess on a CT. And the problem with dry wood is that it has got a high air content, so may be mistaken for air bubbles. So CT is not very useful for wooden foreign bodies, and in such cases you have to go for an MRI orbit. MRI can detect organic and glass objects with greater sensitivity, but MRI is contraindicated when you do not know what is the nature of the foreign body or if you're suspecting metallic foreign bodies, because a magnetic field can cause change in the position of foreign bodies and more damage. A UBM or an anterior segment OCT can be done if you're suspecting an angled foreign body. The advantage of UBM is that you can screen behind the iris and the ciliary body also, whereas in anterior segment OCT, the foreign bodies behind the iris may be missed. ERG can be used for prognostication of metallosis like sidrosis and chalcosis. Now coming to management. So you know the goal of the surgery is is required, or the removal of the foreign body is needed. So the goal of surgery is to prevent further damage and to restore the ocular anatomy. Functional restoration of visual gain is only secondary, which has to be explained to the patient. And the first step is the primary repair of the ocular cords. A meticulous repair of the corneal and the scleral wounds is extremely important, and the anterior chamber has to be formed. If the eye of P is in the anterior chamber on the angle, it can be removed by viscoexpression, by using a magnet if it is magnetic, or with forceps. And make sure that you do not remove it through the direct entry wound. A separate incision has to be made. And if as lens management has already been done with. For intraocular foreign bodies, these foreign bodies which are impacted in the crystalline lens. The problem here is that if the foreign body remains in the lens for quite a long time, the lens can become cataractous. It may become mature. In such cases, the foreign body may not be seen and the entry wound may be very, very small. So in such cases, there is a chance that you can miss the intralenticular foreign bodies. If you're suspecting intralenticular foreign bodies, avoid a hydrodissection because a PC rent can cause the foreign body to fall posteriorly. So this is a patient who was a stone breaker. He came with an history of injury 5 weeks before. He presented with a mature cataract. And so a routine cataract surgery was being done here. So you can see a small incision cataract surgery is done. Now managed like a normal cataract. But after cortical aspiration, you find something shining at the posterior capsule. This is actually a metallic foreign body which was missed and was diagnosed intraoperatively because there was no other external injury. Posterior segment foreign bodies are routinely managed with a 3-port vitrectomy. If the lens is cataractous, the lensectomy or cataract surgery can be done. So this is a patient, young patient with a metallic foreign body presented 1 week after an injury. So you can see a vitrectomy is being done. You can see an encapsulated foreign body near the ora serrata. So with a cutter, I'm slowly disengaging it. It jumped onto the posterior pole. However, no damage was done. And because it was very small, one of the ports was enlarged. And with an intraocular forceps, the foreign body is gently picked up without causing any damage, and it is slowly removed through the port. So in this patient, we were able to salvage the lens, and we were even able to leave the patient without any tamponade, and the patient recovered well with a 6/6 vision. However, in very severe cases like this, so you see a very large penetrating corneal wound which has been repaired, lens is cataractous, vitrectomy is being done. So you see a large foreign body that is impacted on the retina. So with the forceps, it is being pulled out. So you see it's almost like a stab wound on the retina. And when it is pulled up, you see how big it is. And so because it was so big, it could not be removed through the pars plana. So it's brought into the anterior chamber. A limbal incision is made, and it is brought out through the limbal incision. So the retina was almost non-salvageable. So, and no tamponade was done because there was a risk of posterior leak of oil. So prophylactic intravitreal antibiotics should be considered in all these cases to reduce the risk of endophthalmitis. All these patients have got a very long-term risk of corneal scarring, cataract, glaucoma, and retinal detachment. And always there is a risk of sympathetic ophthalmia in 0.5 to 2% of cases. A very short note about sidrosis. Sidrosis happens due to chronic iron foreign bodies. So you can have a heterochromia of iris. You can have a brownish pigmentation of the cornea, the iris, and the anterior lens capsule, anterior capsular cataracts, and also an retinitis pigmentosa like changes on the retina. And in chalcosis, it produces greenish discoloration of the cornea, producing a Kieser-Fleischer ring, sunflower cataracts, and if the copper content is very high, it can result in endophthalmitis. So the take-home message is that the details about the mode of injury has to be elicited from the patient. You should have a high index of suspicion. Always look for an entry wound. It may be missed. It may be very small. Always, always, always do a dilated fundus examination. Only then you can see the lens track and a posterior IOP. And timely intervention is extremely essential. Thank you.